today we will be discussing about the clinical presentation, laboratory investigations, and treatment in case of ARDS. Now, remember that ARDS is a long topic, so we are in this section discussing about the initial clinical presentation and the laboratory investigations required for this condition. So, before moving on, let's understand first the historical aspect of this condition. Now, when you talk about the historical aspect, the American European Consensus Conference, that is the AEC, traditionally divided this entity into two parts. We called it acute lung injury, and then we had acute respiratory distress syndrome. Now, acute lung injury, both of these conditions had a lot of similarities. Both had an acute onset. Both showed bilateral infiltrates consistent with pulmonary edema on chest X-ray. Both had a non-cardiac etiology. That is, no clinical evidence of left atrial hypertension, or if measured, the pulmonary artery wedge pressure was less than equal to 18 millimeters of mercury, or the pulmonary artery occlusive pressure was less than equal to 18. The difference was that in acute lung injury, we considered a PF ratio of less than or equal to 300 millimeters, whereas the PF ratio was less than or equal to 200 in cases of ARDS. So, what is actually missing over here is PEEP. So, why PEEP is important, or what does an increase in the PEEP give you? So, whenever the PEEP is increased in any condition, increasing the PEEP uh, increases the PaO2, or the partial pressure of oxygen, at a given FiO2. Without the PEEP, the values of PF ratio, if they fall to less than 300, this may reflect a simple atelectasis. So, if by this definition, if we're saying that the PF ratio falls less than 300, without asking about the PEEP at which this was measured, it can also occur in cases of atelectasis. That is what they're trying to signify over here. Then, thirdly, this PEEP may recruit sufficient atelectatic lung to raise the PF ratio to more than 300. So, that is why PEEP is very important. So, coming to the Berlin definition, which was later on derived from all these observations, the onset in ARDS is within 1 week of the clinical insult known to result in ARDS. Secondly, the hypoxemia was less than or equal to 300 at a PEEP or a CPAP of more than or equal to 5 centimeters of water. The chest radiography showed bilateral opacities which were not explained by effusion, nodules, or any atelectasis, and there was a non cardiac etiology, that is, a respiratory failure which was not fully explained by cardiogenic pulmonary edema, and you have to exclude hydrostatic edema if no clinical risk factor is present. The condition is itself divided into mild, moderate, and severe. Mild when the PF ratio is less than equal to 300, moderate when the PF ratio is less than or equal to 200, and severe when the PF ratio is less than or equal to 100. Now, the identified categories of mild, moderate, and severe, they correspond with progressive increases in mortality. This would be discussed in the subsequent sections. Then, coming to the factors now, we have talked about a lot about the etiologies. So broadly speaking, we have divided the etiologies into the ones which cause a direct impact and the ones which cause an indirect or a systemic impact. So direct precipitating causes of ARDS include aspiration of gastric fluids, bacterial pneumonia, especially diffuse type seen in Legionnaire's disease, chest trauma with lung contusion, near drowning, pneumonia due to pneumocystis carinii, toxic inhalation, for example, smoke inhalation, inhaled crack or cocaine, viral pneumonias, for example, influenza, SARS, and SARS CoV 2. Indirect precipitating causes include acute pancreatitis, blood transfusions with transfusion related acute lung injury, post cardiopulmonary bypass, primary graft failure of lung transplantation, severe sepsis and septic shock, toxic ingestions, for example, aspirin or TCAs, trauma with multiple fractures, and the fat emboli syndrome. Then, based on these etiologies, there are certain factors which influence the risk of ARDS. That is, these conditions may pose as a higher risk of ARDS, whereas there are certain factors which may influence the mortality for ARDS. So, the factors which may cause an increased risk of ARDS include chronic alcoholic abuse, hypoproteinemia, advanced age, increasing severity, and extent of injury or illness as measured by injury severity score or Apache score, hypertransfusion of blood products, and possibly cigarette smoking. High BMI in itself is also associated with an increased risk of ARDS. Then diabetes mellitus and pre-hospitalization antiplatelet therapy that appears to decrease the risk of ARDS. Then the factors which cause an increase in the mortality include advanced age, a lower PF ratio, a high plateau pressure, which signifies a low respiratory system compliance, greater extent of pulmonary infiltrates, sepsis, chronic liver disease, non pulmonary organ dysfunction, increased global severity of illness, hypoproteinemia, and greater length of hospitalization prior to onset of ARDS, and increased dead space. Now, there are certain tools and scores that have been developed to predict ARDS. There was one such score which is known as Lung Injury Prediction Score, or LIPS, which was aimed at identifying those at higher risk of developing this condition. Now, this was generated from the sum of points assigned for each six predisposing conditions and nine risk modifiers. The predisposing conditions included shock, aspiration, sepsis, pneumonia, high risk surgery, and high risk trauma. The nine risk modifiers included alcohol abuse, obesity, hypoalbuminemia, chemotherapy, need for oxygen, tachypnea, hypoxia, acidemia, and diabetes mellitus. So each of these points have been given a score of 1 and you add them both. So if the score is less than 4, the negative predictive value, that is, to rule out ARDS, the negative predictive value is 97%, while a score of more than 4 has a sensitivity and specificity for diagnosis of ARDS at 69% and 78% respectively. So what does this signify is that if you can get a LIPS score of less than 4, you can safely rule out ARDS, right? That is the whole significance. Now, coming to the let's now come to the next section, the clinical presentation and the diagnosis. Now, firstly, let's understand the pathology and physiology behind it. Now, we have studied in the previous sections that all this is due to inflammatory cytokines. So, based on this, there are certain early changes and then there are certain late changes. Now, early changes are the ones which develop within few hours or days. The pathognomic entity associated with this is diffuse alveolar damage, which is nothing but inflammatory cells becoming more numerous within the lung interstitium and extensive necrosis of type 1 alveolar epithelial cells. This condition eventually leads to two parts. Either it can cause alveolar edema or it can cause alveolar collapse. As a result of alveolar edema, what happens is that a shunt is formed. And characteristically in ARDS, we say, and this would be coming up recurrently in the subsequent texts, that hypoxemia in ARDS is resistant to supplemental oxygen. This condition reflects a right to left shunt. Continued perfusion of alveoli that lack ventilation because of alveolar edema results in VQ ratios of 0. Obviously, you ventilate the lung as much as possible. Infinite ventilation with zero perfusion, that is going to lead to zero ventilation, but infinite perfusion would lead to the ratios being 0, and this eventually would define what a physiological shunt is all about, right? Then alveolar collapse is something that happens when you have a loss of normal surfactant related stabilization. We all know that surfactant's role is to prevent the alveolar collapse and the end of expiration. So surfactant in this condition, as we have studied in the previous sections, is eaten up by the neutrophils by various mechanisms as well as antioxidant or reactive oxygen species. So this leads to alveolar collapse, right? Apart from the diffuse alveolar damage, we also have hyaline membrane formation and the protein rich pulmonary edema that, when ensues, causes the clinical effects. This was all about the early phase. In the late phase, or proliferative phase, there is disordered healing and proliferation of fibrous tissue. That is why we call it as a proliferative phase. What proliferates? Type 2 alveolar cells, fibroblasts, and myofibroblasts, they proliferate. This happens approximately 7 to 10 days after the initial injury, and as a result of this, there is increased dead space fraction, high minute ventilation requirement, pulmonary hypertension, and further reduction in the lung compliance because of the accumulation of the fibrous tissue. This condition leads to an increased dead space, high minute ventilation requirement, pulmonary hypertension, and further reduction in the lung compliance. Then coming to the clinical presentation. Now, clinical presentation of ARDS typically happens within 12 to 72 hours. The patients are anxious, agitated, and dyspneic. There is increased work of breathing, small tidal volumes, and patient has tachypnea. Pulse oximeter readings are generally less than 85%. Like we said previously, the hallmark is hypoxemia that is resistant to oxygen therapy because of a large right to left shunt. This condition in the initial stages is compensated by the patient hyperventilating. So, whenever the patient starts hyperventilating, what happens? There is a CO2 washout, which causes a condition as acute respiratory alkalosis. But remember that this condition only happens in the initial stages. As the patient starts experiencing muscle fatigue, this leads to more accumulation of carbon dioxide and eventually patient lands into respiratory acidosis, right? Then after that, the next part is differential diagnosis. Now, what are the differential diagnoses that you should consider in mind? So, first of all, let's understand the differential diagnosis of an acute hypoxemic respiratory failure. So, when a patient presents to you with acute hypoxemic respiratory failure, that is a PaO2 of less than 55, in these conditions, the differentials include ARDS, acute cardiogenic pulmonary edema, bilateral aspiration pneumonias, lobar atelectasis of both of the lower lobes, severe unilateral low lobe atelectasis, especially when patient is receiving vasodilators such as IV nitrates, calcium channel blockers, or sodium nitroprusside that blunt the hypoxic vasoconstriction. Acute loss of ventilation to one lung due to complete or near complete obstruction of the main stem bronchus, loss of ventilation to one or both lungs due to large pneumothoraces or pneumothorax, loss of ventilation to one or both lungs due to large pleural effusion, diffuse alveolar hemorrhage, especially in patients post bone marrow transplant, massive pulmonary embolus, acute opening of the patent foramen ovale in patients with pre existing pulmonary hypertension. After this, there are certain differential diagnoses of ARDS itself, so that should be kept in mind. So, if a patient is presenting to you with a history of cardiac disease, enlarged heart on chest radiograph, a third heart sound, and there is rapid improvement with diuresis or afterload reduction, then probably you're dealing with a patient of pulmonary edema due to left heart failure. Then, if there is a history of one or more precipitating causes, which have been discussed in the previous part, crackles are absent or not prominent, the cardiac size is normal on chest radiograph, then you're probably dealing with non cardiogenic pulmonary edema. This is a usual etiology for ARDS. Rarely, some patients with ARDS have no obvious precipitating cause as well. Then we have a condition known as diffuse alveolar hemorrhage. This most often is associated with autoimmune diseases like vasculitis or following bone marrow transplantations. Patients most of the times do not have a bloody sputum. Renal disease or other evidence of systemic vasculitis may be present. Hemosiderin laden macrophages and bronchoalveolar lavage fluid can confirm diagnosis of DAH, may respond to apheresis, corticosteroids, or cyclophosphamide depending on the etiology. Now, DAH may meet diagnostic criteria for ARDS, but altogether it has a different pathophysiology and the management. Acute eosinophilia. Again, a condition where the patient has cough, fever, pleuritic chest pain, and myalgia. Patients often do not have peripheral blood eosinophilia, but they have greater than 15% eosinophils in the bowel. Usually, they respond rapidly to high dose steroids. Now, this condition also meets the diagnostic criteria for ARDS, but again, the pathophysiology and management is entirely different. Then we come to lupus pneumonitis. Now, this is associated with active lupus, and these patients respond to high dose steroids or cyclophosphamide. Again, this may meet the diagnostic criteria for ARDS, but it has altogether a different pathophysiology and management. Then, acute interstitial pneumonia has a slower onset than ARDS. It takes 4 to 6 weeks with progressive courses. However, it may present in advanced state, mimicking the ARDS. Now, AIP in itself is associated with more than 90% mortality. It includes Hammond-Rich syndrome. Then we have pulmonary alveolar proteinosis. This has even a slower onset than AIP. That is, it takes approximately 2 to 12 months with progressive course, and it can be treated by whole lung lavage. Characteristically, you get a crazy paving pattern on HRCT. Then BOOP or cryptogenic organizing pneumonia. This may be precipitated by viral syndromes, very commonly seen these days in case of COVID. Slower onset than ARDS, that is over more than over 2 weeks with progressive course. However, this may be present in the advanced state, mimicking the ARDS and may respond to high dose steroids. Then HP has a typically slower onset than ARDS, takes approximately weeks with progressive course. However, this may present in advanced state mimicking ARDS and they may respond to high dose steroid, but removal of the offending agent, that is the key. Then leukemic infiltration. This may be rapid in onset during active disease states. Usually, leukemia is clinically apparent. Then, drug induced pulmonary edema and pneumonitis. This may follow the use of opioids, heroin, or overdose of aspirin and others like TCAs, and this patient may progress to overt ARDS. Then, acute major pulmonary embolism. This occurs acutely, occasionally accompanied by severe hypoxemia that may be resistant to oxygen therapy, like ARDS, and by hypotension requiring pressors, mimicking ARDS with sepsis. The patients typically have risk factors for acute pulmonary embolism and may not have common precipitating causes of ARDS, like patient having an active cancer or having a history of hemoptysis, or if the patient has been immobile for some time. So all these factors are not the precipitating causes of ARDS. And remember, the chest X-ray in ARDS should have a bilateral infiltrate consistent with pulmonary edema. However, in acute pulmonary embolism, they may have unilateral findings or there might be no infiltrates at all. Acute pulmonary embolism needs, of course, a confirmatory study, for example, a CT with pulmonary embolism protocol or a CTPA or a VQ scan. Then sarcoidosis. Now, sarcoidosis, we know the onset is not acute. Uh, but its clinical recognition may be oxygenation is impaired and chest X-ray may be diffusely abnormal. Historical features and the frequent presence of hilar adenopathy in sarcoidosis usually eliminate confusion with ARDS. And finally, we have IPF. The onset is never acute, it's clinical recognition, but its clinical recognition may be, and oxygenation is often impaired, and chest x ray most of the times is abnormal. Uh, it's important that you scan the prior chest x rays and look out for a history of chronic and progressive dyspnea characterizing this condition of IPF, right? Then, after discussing this, let's come to the laboratory investigations. Now, laboratory investigations in case of ARDS are further divided into radiological investigations, laboratory studies, echocardiography, invasive hemodynamic monitoring, bronchoalveolar lavage, and lung biopsy. Now, in the cases of chest X-ray, typical chest X-ray for ARDS would give you a diffuse bilateral alveolar infiltrates consistent with pulmonary edema, and there are patchy peripheral infiltrates that extend to the lateral lung margins as well. Now, remember that the extent of the lesions may not correlate well with the degree of hypoxemia. It's not necessary that more the infiltrates, more severe would be the hypoxemia. That is not the case. Then, chest radiography in the early stages may be variable, mild, or dense interstitial or alveolar, patchy, or confluent shadows may be seen. To distinguish, then again, it is very important for us to distinguish hydrostatic edema, that is cardiogenic edema. So, in cardiogenic edema, in on chest X-ray, you get a vascular redistribution towards the upper lobes and presence of septal lines, that is a curly B lines, or a perihilar distribution, that is a bat wing appearance of the edema, right? So these are the findings that you get on chest X-ray. Then coming to the laboratory investigations. Now this includes firstly ABG. Like previously stated, in the early stages due to hyperventilation, patient may have an alkalotic picture, but in late stages due to respiratory muscle fatigue, patient may have hypercapnia and eventually acidosis. Then you should also rule out other causes of respiratory failure using laboratory studies, say for example cardiac enzymes. But remember that cardiac enzymes always need to be measured in conjunction with echo findings, because if the TROP-T is positive in ARDS, it's not necessary that it is only due to cardiac problems. Sepsis in itself can also cause TROP-Ts to be positive. Then BNP is another test that you can do. If the BNP is more than 500, then that would indicate CHF, but with a positive predictive value of 90%. If the BNP is less than 100, then one thing that is for sure that congestive heart is unlikely, and this has a negative predictive value greater than 90%. But remember that BNP levels increase with renal failure also. So if you have a value of more than 500, this may even occur in a patient who has presented to you with sepsis and a normal left ventricular function. So normal left ventricular function with a BNP of more than 500, well, that could signify some, you know, uh, patient in a sepsis. Then coming to echocardiography. Now, echo is generally done to evaluate potential cardiac causes, right? So, cardiogenic pulmonary edema is basically ruled out. The findings which suggest cardiogenic pulmonary edema include mitral valve stenosis or regurgitation, left ventricular dilatation and systolic dysfunction, or regional left ventricular motion abnormalities. Coming to the invasive hemodynamic monitoring. Invasive hemodynamic monitoring is done through pulmonary artery catheterization. Now, this is a very controversial thing, as the data obtained from the pulmonary artery catheters is inconsistent and often erroneous. The reason why I'm saying is that initially what we studied in the AECC definition was that the non-cardiac etiology should be taken into account. That is, a pulmonary artery wedge pressure should be less than or equal to 18. If it is more than or equal to 18, then probably you're dealing with a cardiogenic edema. But the FACT trial showed that the elevated pulmonary artery occlusive pressure likely reflected intravascular volume loading rather than cardiogenic pulmonary edema. So it was something that was very commonly seen in patients of ARDS. So that is why, strictly speaking, a pulmonary artery occlusive pressure of less than 18 does not really guarantee that it is a cardiogenic cause, that there is a cardiogenic cause behind it, right? Then coming to bronchoalveolar lavage. Now, bronchoalveolar lavage is done in patients who have ARDS of unclear origin. This is done either to rule in or rule out acute processes that may have specific therapies. Now, remember that bronchoalveolar lavage is contraindicated in cases of very low PaO2 or those requiring high levels of PEEP. So, in these patients, you would not do a BAL. But like we said, to rule in or rule out certain conditions which can have a very specific treatment, like in case of acute eosinophilic pneumonia, we said that if the bowel fluid is giving you an eosinophil count of more than 25%, then that means it is acute eosinophilic pneumonia and they have an excellent response to steroids. So that is why it is important. DH, on the other hand, like we said, give you a blood tinge fluid and can happen following blown bone marrow transplantation or in association with vasculitis, and you get hemosiderin laden macrophages as well. So that is also very important. Then so that is also, and DH also has its treatment, so that is why it is very important. Then apart from that, we also have lung biopsy. Now, lung biopsy is done if all the alternative etiologies of respiratory failure have been safely ruled out. So in these conditions, we would go for a lung biopsy. So with this, we end the discussion on the laboratory investigations, clinical presentation, and certain other aspects. In the next section, we'll be talking about approach to the treatment, as we know that this is a pretty big section to first understand. So yeah. Uh, we'll be wrapping up this session from now. Thank you for your patient listening.